Hi, I'm Greg Dell, and today Stephen Jessup and I are going to talk about back disorders and how they relate to short-term and long-term disability claims. Steve, one of the most common disabling conditions that we see for claimants, I would say, would have to be with some kind of disorder of the mid to lower back, which would be the lumbar area or the thoracic region, especially as people get well over 40 into their 50s. There's just deterioration of the spine. It's just the way we're built, and that's what happens. It's known. So in these claims, very often the disability carriers are looking for objective evidence of a back problem. The problem is that from the medical literature, 80% of people that have back pain, there's an unknown etiology, meaning unknown, we don't know why it's happening. But let's first start with the easy part. What is the objective evidence that's the most supportive for a disability claim for somebody with a back problem?
Well, I think the number one you're going to see are MRIs, especially if it's anything doing with bulges, herniations, things along those lines. You see CT scans, sometimes X-rays can document it. And then if we go beyond that, if there's issues, especially into the lower legs with radiating pain, where there's EMG or nerve conduction studies to document any of the radiculopathy stemming from the back problem.
Okay. How important is this type of objective evidence in getting a disability claim approved?
It's not an end-all be-all, but it's certainly very important because that's what the insurance companies are trained for. If there's not a known cause for the problem, more and more policies are containing what they call self-reported symptom limitations, where if essentially there's no objective evidence of why you're having these problems, they're going to limit your claim to 24 months, and pain is one of the biggest ones. So having the MRI, having this objective evidence, even though it's not going to say the insurance company is going to say, oh, because you have this, we're going to approve disability, it at least gives you a firm foundation to be able to argue this is why restrictions and limitations would be appropriate.
Okay, so the objective evidence I wouldn't call it the easy case. I mean, it's helpful because how often do we see people have horrific objective evidence and the disability carrier says, no, we think you can work, because we know that diagnosis doesn't equal disability. I mean, there's plenty of people who can be completely asymptomatic, which means they have no pain whatsoever. They get an MRI and they have the worst herniation you've ever seen, but it doesn't bother them. And that's what we work on when we present claims to the people who don't have the strong objective evidence. And that statistic, which is known, that more than 80% of people who have chronic debilitating pain don't necessarily have the strong objective findings, that the disability carriers can't necessarily say, well, you don't have this strong objective finding. Well, so what? It doesn't mean I don't have pain because the literature says I don't. So what other types of things can a claimant do to try to prove their claim if they don't have strong objective evidence in like an MRI?
Well, some of if there's not strong objective evidence, and even if you do have strong objective evidence, you do have to draw that correlation to here's what the medicals show, and here's why I'm having these restrictions and limitations. So there may be a ground for functional testing at that point, functional capacity evaluations, which are going to give an idea of what your physical abilities for work are. It's by no means an exact science or a perfect science, but it does correlate over to what the insurance company is going to use from the Department of Labor's physical demands: sedentary, light, medium, heavy, etc. So functional capacity evaluations are probably one of the first and most important pieces of information to present that.
Okay. The other thing I would say, and a functional capacity exam is another tool that we've used, and we have, we've worked with functional physical therapists or doctors that administer those tests all over the country. But it really gets down to, and we see this in the case law all the time when we litigate, how good the documentation is from the treating doctor. Because how often do you see, I'm barely even seeing the complaints of pain from the claimant in the records, but I'm also not seeing the physician document what's going on. So what are some things that you'd like to see in a claim in a doctor's records that show that the person is actually suffering from what they say?
Well, the biggest thing is going to be the doctor. Usually most of them will give them an opportunity for the doctor to give a summarization of the treatment, that appointment, laying it out, what those problems are, whether issues with bending,
right, the range
of motion, all those types of things. And even more so, and I think a lot of people, if you're watching this, especially maybe in your records, doctors may write that in those sections and document that well. But in the portion of the chart note where they just hit a button, it may say no distress, everything's fine. And there's a contradiction in the records itself, but the insurance company will gloss over what the doctor wrote for those simple, most times check the wrong box or just went through it too quickly. So it's really a matter of the doctor taking the time to show those range of motion issues. Problem with, movement. If they notice especially person is, hunched over while they're walking, they're changing, moving positions in their seat during the exam, those indicators of a pain response.
Right, and then the gait is the way you walk. So you brought up a good example, as you said, in the computer, check the box. Nowadays, especially with the HIPAA regulations, everybody is moving really to this totally paperless world. So all of the medical records, when you go sit with your doctor, the doctor's either typing something right into the computer or dictating records, which then get transcribed and typed into the system. But you're right, because there's all these boxes for the standard forms for the treatment of a patient. And it may say in there for a person who's telling disability care, well, I'm walking with a limp. Well, then it says in there normal gait. So the claimant looks like a liar. And that is like a classic example of a claim that gets denied, because the person could be walking very poorly, but then the medical record says no abnormal gait, no complaints of pain with bending, no complaints with pain of sitting, no complaints of, but it's just a form that the doctor didn't change. And so when we're involved with the claim, we're always requesting the medical records, we're always reviewing them to eliminate those kinds of pitfalls that can result in a claim denial. That brings me to the other thing, that I know that we always get the medical records, but what should a claimant do when talking to their doctors about making sure the records are correct?
I would request the record. I mean, as a patient, you do have a right to your records. So, ask for the treatment records up to that point. In some instances, I have clients who are able to get it same day after the appointment. It's done so quickly, just to make sure if there's any error or mistake or omission, that it's corrected as soon as possible before an insurance company makes the request or they're submitted, to the carrier.
Right. So the biggest challenge a claimant's going to have is that doctors are there to treat the patient. They're not there to document the medical records for all of the nuances that the long-term disability insurance carrier is looking for. And because of that, the long-term disability companies jump all over the doctors and the claimant by saying your records don't say A, B, C, D, and E. And we know that when we see it, because the doctors are more concerned about, if you went in there, they'd say, Steve, how do you feel today? And you'd be like, well, I'm a little better than last time, but otherwise I'm just getting by. Now you've been dealing with this back issue, for 2 years hypothetically, and the doctor just says, okay, continue taking the meds, or I see that you're having, negative straight leg raise test today and difficulty with range of motion, and then that's it. And it becomes a problem. And even for the claimants who are on claim for years and years and years, the records don't continue to specify the problems. And that's why we see on average denials 3 years, 5 years, 7 years out, because the medical records become weak. So the message is, you can never let your guard down with how the doctors are documenting the records. And when we're involved, we'll train you and we'll work with your doctors to make sure that everything's documented appropriately. So no matter what stage your claim is at, whether you're looking to apply, you've been denied, you're just tired of dealing with the insurance company, you'd like our help, we offer a free consultation. We're available to help you anywhere in the country, and we look forward to the opportunity to speak with you.